Hi, everyone. Good evening. My name is Catherine Mickelson. I'm the Executive Director of the North American Thrombosis Forum. Thank you so much for joining us for Ask the Expert this evening. Before we get started, I did have a few announcements. All lines will be muted for the duration of the program. So if you want to ask a question, please enter it into the chat box in your control panel. If you are not able to use the chat function, you can also email your question to events@natfonline.org, and we'll be monitoring that inbox for questions that come in during the program as well. So at NATF, we spend a lot of time talking to specialists in the fields of cardiology, vascular medicine, hematology. But tonight, I'm really excited to be talking to a clinician who I think is really the cornerstone of good health, which is a primary care physician. Dr. Julie Anderson is a family physician from St. Cloud, Minnesota. She's the owner of Simplicity Health, a multi-specialty clinic serving patients of all ages in the St. Cloud region. Since completing her training, Dr. Anderson has been active in the American Academy of Family Physicians, holding many appointments and recently serving as the Minnesota chapter president. Nationally, she has served as the Minnesota delegate to the AAFP and as a member of the Commission on Governmental Advocacy. And she recently finished her time as president of the American Academy of Family Physicians Foundation. She was also recently honored as the Minnesota Family Physician of the Year. So welcome, Dr. Anderson. We are absolutely delighted to have you this evening.
Thank you so much. I'm happy to be here.
Great. So if you want to start, kind of before we dig into the questions, just kind of telling us a little bit about yourself and your practice so we can get to know you a little bit.
You bet. So I went to the University of Minnesota Medical School, and that was about 16 years ago. I've worked for most of my career in a larger multi-specialty group, but about 3 years ago, I left that organization and started my own practice, a private practice that is now grown to 7 providers, and we are just making our move to a brand new building this week, actually, to expand. And we offer surgical, pediatric, sleep specialty care, and then we're going to also add telepsychiatry because we know that and recognize that behavioral health is such a large part of what we do in the clinic setting. So I see patients of all ages. I enjoy practicing kind of the full scope of family medicine, which as our population has grown, and as I've aged, I should say, not grown, but grown up, we've also had to shift our framework and our focus a little bit on the aging conditions. So things like atrial fibrillation and whatnot are becoming more and more popular terms in my office than they were 10 years ago when I was serving a younger population.
Oh, interesting. What is the demographics for your patient population?
I would say we serve about 20% of our patients are Medicare age, so 65 and older. And then otherwise, we're seeing, the spectrum of the age. Men and women, as you probably know, women are more likely to go to the doctor than men, especially when they're younger. So we do see a lot of women and a lot of children, but just a little bit of everybody.
Okay. Great. So we got a bunch of questions in advance, and a few have come in already. And they're really kind of divided into two categories. The first is just kind of general questions about what you can go to for your primary care physician, and then more related to blood clots. So I thought we'd start with the PCP questions and then kind of roll into the questions specific to things like blood clots and anticoagulation.
Okay.
So can you tell us what really is the role of a primary care physician in managing a chronic condition such as atrial fibrillation, or DVT or PE that, requires ongoing care? And then also, at what point do you tend to refer patients to specialists?
Sure. I think it does it does matter. I think what your comfort level is. First of all, there's family medicine in general is such a broad encompassing specialty. And so some of my colleagues have chosen to do more obstetrics, gynecology. Some primary care physicians tend to focus more on elderly care. Some are more pediatric based. It also depends on your environment in which you're practicing, your community. But I would say the vast majority of us as primary care physicians are trained across the board. That means that we're somewhat of a jack of all trades, master of none, and we're okay with that. It's just that we're trained to figure out when and if people need specialty care. So I've always referred to our specialty as healthcare navigators, especially as things have become more complex. We have more options available for treatment. We have more imaging studies that are available to figure things out, and studies and labs and on and on and on. And you throw Dr. Google in there, and it's fairly challenging and overwhelming for a patient in the modern era to understand healthcare. It's interesting because, 30 years ago, people didn't know a lot about their healthcare because they didn't have the access. You had your Britannica encyclopedia at home, and that's about it, in terms of knowledge on healthcare. And now the sky's the limit. Patients know stuff before I do a lot of times, and so and now we've kind of swung back to where we have so much information, and it's become a little daunting and challenging because, and I know most people have done this where they, Google headache, and you're not going to like the first 5 diagnoses that come up, even though most of the time it's just a headache, it's a tension headache or whatever. So I think we do where we're helpful in the modern era is to sift through all of that and figure out when it's appropriate to stay in the primary care setting, because we should be able to handle 90% of what comes in the door. And then when it's appropriate to get either extra imaging or evaluation as it pertains to AFib, whether they need to go in for an echo and a Holter monitor or something more, or maybe because of X, Y, and Z conditions, we feel like they need a more specialty evaluation.
Okay. So specifically, we have a lot of patients on the call who are on anticoagulation, and, indefinite duration. So in terms of managing their anticoagulation, specifically for those on warfarin, but also for, a lot of the patients who are on DOACs now, should that typically fall with the primary care provider? Or do you tend to outsource that to anticoagulation clinics or something like that?
We manage our own patients that choose us for managing their care. We do a lot of remote monitoring with, the remote products for patients that are able to do that from home. We have a very, an algorithm that we follow that most places follow the same kind of algorithm, but there is a little bit of an art, as most people probably realize, to managing, especially the warfarin. But where I think it becomes challenging for primary care settings is if they don't have the bandwidth to manage, or if they have a huge number of patients, and especially if you're in a small clinic like mine, you don't have the infrastructure of a health system that has, a whole setup of warfarin nurses that are managing, these. I personally like to manage it myself, because then I know where my patient's falling, and it keeps me in touch and contact with the patient more often, because they are higher risk population.
Yeah.
But most
Yeah.
of the time, it should be able to be managed. There's nothing magical about adjusting, dosing for INRs.
Mhm. Yeah. Now, you mentioned at-home testing. We get a lot of questions about how to get a machine covered by insurance to do at-home testing. And there doesn't seem to be one really good resource for that. Do you have any tips for patients who might be interested in that?
Well, I can tell you what we do, and it may be different, in different areas of the country. I'm not sure, but the product that we work with is MDINR, and our all we have to do is we have a simple form, and I think my nurses even do that online now, where if the patient's interested, we submit it, and then that company actually does all the legwork, which saves my clinic time and effort, and saves the patient time and effort.
That's
And
great.
and so, you have to make sure that you're appropriate for that, that your INRs are pretty stable, that you've been on warfarin for a year, and that you're able physically to. Some people just, are unable to, do that kind of check. It's like a sugar check for diabetes. It's fairly simple, but just you have the ability to do that as well, or a family member has the ability to do that for you.
Yeah. Yeah.
Because it is hard and challenging for certain populations to come into the clinic weekly or monthly or whatever it ends up being.
Yeah. Yeah. No, definitely. I also know, like, to your earlier point about, these patients tend to be a higher risk population, that a lot of the patients who are on warfarin choose to stay on warfarin because they really like that touch point with their clinician. And there's a real sense of safety there, is what we're hearing, about I know it's working because I know exactly what my INR is. Um,
There's probably some socialization piece to that, in that population, especially in today's world with COVID. I mean, so many elderly are isolated and don't have the interactions with people, and so when they do come in the clinic, it is somewhat of a social, in a small
yeah,
way, social outing for them.
absolutely. Absolutely. So sticking with the topic of anticoagulation, how do you have the conversation with your patients about warfarin versus one of the new anticoagulants, such as Xarelto or apixaban, something like that?
Sure.
How do you make
Uh,
that decision?
Yeah, so I think you have to make sure that they're appropriate for it, that they don't have a underlying valve disorder, for example, or some other complicating factor. Um, if they've had strokes in the past, there might be, or if they're already on some other anticoagulants, we might need to have. That's when the specialists get involved to kind of sort through what's most important. Um, and unfortunately, it does often come down to coverage for insurance. I just had a 95-year-old patient of mine who it's challenging for her to come into the clinic because she doesn't drive. She's got to call one of her family members. It's challenging for them to get her in even once a month. She's pretty stable on her warfarin.
Mhm.
And, she said, well, my family was asked if I could go on one of those and those other new medicines. And so we check with their coverage, and if it works out for them and they're a candidate, obviously that makes it a lot easier for somebody that has some transportation issues,
Mhm.
or that just doesn't want to come into the the clinic all the time too, or that they're very challenging. They have labile or very frequently changing INRs. That's real challenging for some too.
Hmm. Definitely. And then one question that just came in was about considerations for taking aspirin instead of an anticoagulant. Do you have any thoughts on that?
Well, it depends on what you're treating. Like if it's, if we're talking about, and I'm assuming we're talking about AFib, but that's not enough of a anticoagulant, for prevention of stroke. You have to kind of ramp it up a little bit, and certainly not at all appropriate if you have a valve disorder on top of it. If you're just talking about prevention, primary prevention, meaning you have no disease, aspirin is, reasonable. So it's all about what you're treating.
Yeah. Okay. So talking about prevention, one of the questions that came in was about being embarrassed to see their primary care physician because of recent weight gain. So I'm curious to hear what your perspective is from a clinician on
Oh
this.
gosh, I always tell people I don't judge. We're and some of us have our own issues with weight too. So it's a human issue. It's not a patient issue, and it's definitely an American issue, probably first world issue.
Mhm.
But there's many factors at play with that. There's many treatments that are out there to discuss, and if you don't feel comfortable, then you probably should find somebody that you do feel comfortable with. Um, I tell people that all the time when we send them to specialists, especially if they're talking about surgery, you want to feel like you have your faith in that person to guide you. And if you don't, there's somebody else out there. It's okay to ask for other doctors, other specialists, other referrals. We do that not all the time, but often, for people because it's your life and you need to be able to feel comfortable and confident. Um, but absolutely, I mean, we're a place of where you're supposed to be able to feel comfortable and get the support that you need, whatever the issue is, whether it's obesity or any other number of ailments.
Mhm. Great. In terms of feeling comfortable, more kind of specific question, but can you talk about seeing your primary care physician in the time of COVID, which I think a lot of patients we hear on the news and through various outlets are putting off care out of fear of COVID. So could you speak to that a little bit?
Sure. We saw that in my community, certainly in March and April when there was just this huge uncertainty of how this virus was even passed, um, and how it infected people. And now that we've learned more, and we kind of understand a little bit more about it, we're back to, in my community, full-time visits in person for the most part. I've had a handful of people that choose to stay home, and we still thankfully have that ability. Before COVID, we were not paid for having a visit online, and I think that obviously was a win for various reasons. If I can do a remote appointment with a patient of mine who's in rehab, for example, I just saw a lady who happens to have AFib, also managing her INRs virtually and seeing her virtually. The nurse would bring in the iPad so that she could talk to me
Mhm.
and see me, and we'd be able to communicate about how she's healing after her ankle fracture. And so we've opened up ways, but that does not allow you to get your screenings for your mammograms and your prostate checks and your pap smears and all that preventive care that colonoscopy is another one where we basically shut down for a couple of months. And
Yeah.
it's been estimated that we'll probably lose, about 80,000 opportunities in those 2 months of screening for disease,
Wow.
including AFib and every other, kind of thing that we sometimes check. You can't listen to a heartbeat very easily. There are methods, but not very easily remotely.
Yeah. With remote visits, are there things that you like patients to do to prepare for those so that, the time is well spent?
Um, most of the first half of my visits are usually, okay, what's going on with the COVID vaccine? Which I don't really know, but we talk about COVID and everybody wants to get that off their chest, and then, but even if it's in person or virtual, the best thing is to have a list, I think, because for some people it's anxiety provoking to talk to a doctor, and I think if you have a list you can always like kind of go back to it and say, oh, I really wanted to talk to you about this and that, and then I'm starting to leave, but then you're like, oh, I really wanted to ask her about this skin thing, and I can just look at it and go, oh, don't worry about it, it's fine. And
Mhm.
maybe that's all you need to know. You just need to be reassured that that's fine. Or it's like, oh yeah, I've been having chest pain is that something to worry about? Well, yeah, we need to talk about that further. Um, so having a list, if you have access to your electronic record, it's helpful to look through it and see if there's any questions that you have about it, because sometimes we're just focused on the certain details of our questions based on your visit type, and we might scroll over something that maybe is really important to you.
Yeah, great. I know you said that you are in the process of adding, I believe you said like a psychology component to your practice.
Right.
Um, so we had a patient with a question. They said they recently had surgery for blood clots. So how do you help your patients deal with fear after a scary diagnosis?
That's a really good question. Because everybody's fear is different, and everybody's anxieties are come from different places, from maybe our different life experiences. Maybe it was some experience with the surgery or the procedure, um, and so I think getting to the bottom of that. Um, Sometimes patients are not as forthcoming about those worries, and we can't always sense it. I mean, we try to, that's the art of what we do is, especially, I guess that's where primary care is better, maybe serving our patients than other specialties, because we get to know you over a lifetime. And so when I've taken care of a family or a person for 15 years, I've seen them for all sorts of stuff, and then they come in and let's say after a surgery event, and they're just acting a little funny or they're not looking at me. I mean, we can cue in on some of those nonverbal cues that we look for, but that's another thing you just have to let us know, what and we can try to address those fears. Whether it's, oh my gosh, I thought I was going to die. And, this kind of brings up things about something else, that's maybe related, maybe not, or maybe they have a friend that had a similar event and they lost their leg. I don't know. I'm just making stuff up. I'm not saying you're going to lose your leg, but yeah. But and maybe we can talk you through. Okay, well, you're on the anticoagulants. You're going to do fine now. It's just that makes it. The anticoagulant makes the clot stay in its place so it doesn't move further. As long as you're on the medicine, you should do fine. Those kind of things. Talking through them.
Mm-hmm. Mm-hmm. So just
Communication.
offering reassurance.
I think, probably I was asked one time what the most important class I took to prepare me to be a doctor.
Mm-hmm.
And do you know what it was? It was acting. It was being in theater and performing in music. And I think it's you kind of pick up on, you read the audience, you read the people that you're performing with, and it's not that I'm just acting what I'm doing, but it makes me comfortable in cueing in on things and knowing the importance of communicating and listening to the other person in the room.
Hmm. Yeah, I actually read somewhere, and I don't remember where it was now, but how, they said if you really want to learn empathy, take up acting classes, because they say it really cues you in to reading other people and kind of picking up on subtle cues that, you might not otherwise. So that's really interesting. Um, so let's talk a little bit about exercise. So this person recently had a PE and they're active, but they are hoping to increase their exercise intensity. How do you advise patients? When is it safe to do that?
So as long as you are anticoagulated and if you're on warfarin in your therapeutic range, or you've been on your anticoagulants usually a couple of weeks. Uh, Depends on the severity of the PE, to be honest. It's more about how you feel. I had a guy who plays, we're the land of hockey here, so he was a little perturbed that he had to sit out for a couple weeks for hockey. And when he got back, it was more, you know, I mean, we were a little concerned that he might cut himself, um, but beyond that, it was more based on his respiratory ability after the PE. He just had one little section, so it wasn't all that traumatic for him. But some people that have larger emboli, can struggle for a few months to get their wind back in their lungs. And so then for those people, it probably makes sense to do a graduated approach, and not try to go out and run the marathon right away, and just kind of, test yourself slowly. But I can't think of any reason not to, unless you've been told, like if you had any heart failure result, as a result of your PE or something like that, that might make things take a little bit more time. I rarely see people with PEs that need any sort of rehab in terms of pulmonary rehab or cardiac rehab.
Okay.
Unusual.
Mhm. All right, so just pay attention to your body and, gradually increase it. So one patient, the question was about supplements. So kind of what are your, I guess, any guidance you have on supplements in general, but specifically they're interested in learning more about fish oil for blood clot prevention.
Most supplements are called supplements for a reason. So the disclaimer that we usually say is that, supplements aren't really as well regulated by the FDA. So we don't have a ton of research on safety and efficacy.
Mhm.
Um, Although anecdotally, I will say that many of my patients do use fish oil for like cholesterol management and building up the omega-3s, the HDL, the good cholesterol in your blood. Um, there's probably little harm in doing that besides smelling fishy. um, you know but in terms of prevention of PEs, I mean, if all I can say is this: if we knew that it was helpful and beneficial, we'd be putting people on it at this point. The other caveat is how it interacts with specifically with warfarin, and I'm not sure about the DOACs, but specifically with warfarin, if you're ramping up some supplement, no matter what it is, we have to be careful about how those interact with the INR. So if you are starting a supplement and you are on warfarin, I would suggest monitoring the INR a little bit more frequently. And then it's okay for you to do it. It's just that we may have to titrate things, and you just don't want to switch. It's just like the diet and warfarin. It's okay to eat spinach, but you just want to be consistent. Otherwise, that will throw you off.
Mm-hmm. Yeah, consistency is key when it comes to INR and warfarin. Okay, so a question that just came in, a woman just had her second DVT event, and her primary care physician referred her to a cardiologist for her DVTs, and she's wondering why would she be referred to a cardiologist for a DVT?
Well, that's a good question. I don't know that I necessarily would, but like I said, some physicians are less maybe less comfortable with, or maybe they want you to have a vascular workup because you've had two. Although usually you can do that with kind of some simple blood screenings for like factor V Leiden and antithrombin 3. There's various kind of a panel that we usually run on people that have had multiple that we say are unprovoked, not from like a surgery or whatnot. The other thing is sometimes if it's in the same vessel, it might be something that, like if you have varicosities, for example, and those are the ones that are you're getting the DVTs in. Sometimes we'll do a venous test called a venous compression study or incompetency scan, and it's a special ultrasound of the veins in the legs, and that can tell us if there's incompetency in the veins, meaning the valves in the veins are not pushing the fluid back to the heart as effectively as they used to, and then they bulge out, and then because they're bulging out, the blood flow doesn't flow like it should, and then you can get stagnant blood flow and get a clot. And so then sometimes a vascular surgeon or sometimes a radiologist will do a procedure, either stripping that vein out, or once the clot is gone, obviously, but and treated, or they'll potentially do what's called a venous procedure, where they thread a little catheter in to the vein and they heat it up, and then it kind of shrivels up and dies, and then it quits clotting on you. So those might be the reasons for it. I certainly would ask why, and usually it's vascular rather than a cardiologist, unless they think something else. There are other conditions of the vessels potentially, I guess, that maybe they have concerns about.
Mm-hmm. Okay, so just ask.
Yep.
Perfect. All right, so to a topic that I'm sure you are ready to be done talking about, but COVID-19 and vaccines, which I know you spend a fair amount of your day already talking about. But are you aware of any complications in patients with a history of AFib or DVT and PE and the new COVID-19 vaccines?
Not that I'm aware of. I did a quick search yesterday to see if I could find anything. The only thing I've heard of is actually somebody had ITP, which is thrombophilia, where the platelets don't aggregate together. There was a physician, I think it was, that had that after the COVID receiving the COVID vaccine. It's, I think, too early to tell if that was related. Did he have it before? There could be many issues with it, but I haven't heard any specifics about it causing a clot, or that it has put you at more risk, or if you have a clot, is it more risk to get the vaccine? I have not heard any of that. The only contraindication I've heard is that if you have and I think it's just for the Moderna vaccine, if you have a allergy to the Go Lightly prep that we usually use and for to clean out the colon.
Oh,
So only if
interesting.
you have that allergy.
Huh. Okay. And is this what we're hearing on the news about people that, have reactions pretty shortly after receiving the vaccine?
I don't know what those are, if they're just and what percentage of those. I don't think we have enough data yet, but there's definitely people have reactions to vaccines all the time. We've just kind of um, been okay with them, and none of them get the press that
Right.
that this one does. Just like flu has never gotten the press that is an historic amount of press and information that we're getting on one virus out of many.
Yeah. Yep, definitely. Okay, and then a final question. What is one thing that you tell all your patients, or that they wish that, or that you wish that they knew?
Is there anything specific or to COVID
Well,
or
just,
to
just kind of,
anything
like
in
I
general?
have an appointment with my primary care physician coming up in February. Like, is there one thing that you wish I knew, kind of, going into that, or any piece of advice?
Well, I think I already said it, but being, trying to be prepared for the visit. Understand that when you are going in for an annual, very it's very easy for patients to just stack up everything that they've had for the last year and bring it all in and want to talk about it all. But understand that the annual visit is kind of more about prevention and finding out, what things we need to do to keep you healthy.
Hmm.
It doesn't mean that we don't want to talk about those things, that we can address them, but in this era of high deductibles and people try to, kind of avoid the doctor sometimes because of cost, and I understand it. Um, I think if we can, and that's partly our job as doctors to say, hey, this deserves more time. Let's see you back, in a month or whatever it is, and really dive into whatever that issue is. Because
Hmm.
it's really hard for us I always had somebody when I trained said, I can really do well at one thing. I can do pretty well at two or three things, but once they stack up to four or five or six, it's just there's just too much going on, and it's okay. Patients don't really understand, how much of that, when my hand's on the door ready to go and I've got chest pain, with the patient, it's like, oh, that's that's a 40-minute, evaluation, there's
Right.
just a lot more to it. So, and we have to own that too as doctors. We need to do a better job of explaining, okay, this is why this is so complicated and this is important and we need to talk about it further.
Hmm.
But
Okay.
don't be afraid to bring it up. We just need to help you figure it out, in terms of in a timeline.
Yeah. Yep. Definitely. And I know I said that was the last question, but we did have one more come in,
Fine.
that they really want asked. But can you
Okay.
talk about getting another blood clot after stopping anticoagulants if your clot was provoked, and kind of what the risk is there?
Well, so the second one wasn't provoked, but the first one was. Is that how I understand it? Or neither of them were provoked?
So it seems that it was provoked.
Okay.
Um, And
twice.
so getting a second clot after that provoked if they stop their anticoagulation.
Yeah, I mean, the more you clot, it makes sense, right? That the more likely you are to have another.
Hmm.
Um, and if it's provoked, I mean, yes, there's always that chance. I mean, even people that never have had a clot have a chance of a clot. So you have to, I think, talk through, make sure first of all that there isn't some underlying other medical condition that's causing that to happen. Or, like I said before, make sure that the vessels are healthy because that often can provoke, or if you're not ambulatory, there's a whole lot of things I think that risk factors that, come into play with that discussion of whether you end up being on lifetime anticoagulant or not.
Hmm.
I think that's the question being asked. So you got to figure those things out first and have that conversation. There are two calculators that we often use. One is the CHADS VASC2 score, and anybody can Google that and you can calculate your risk and it will tell you, okay, in the next year you have a 7.4% chance of a clot if you don't treat it, meaning you don't anticoagulate. And then there's also a has bled score system. These are all acronyms. So CHADS VASC2 and CHADS 2 VASC or CHADS VASC 2. And then the other one is the has bled that will tell you on anticoagulants what your risk of bleeding is, because that's always the crux of the trouble, of the treatment, is that some people that either have really bad liver disease, let's say, or they're very elderly and they fall all the time. You don't
Hmm.
want Grandma Bessie that's 92, maybe she has AFib, but maybe she falls all the time and she's got really bad liver disease, and maybe the family and she make a determination that maybe the best thing for her is just to not anticoagulate. Sometimes we have to make those tough choices.
Hmm. Hmm. And just real quick, we got a comment. Can you spell out the acronyms? So I
Yeah.
think, go
Oh,
ahead, I'm sorry.
go ahead.
Well, it's has bled, HAS.
HASBLED.
Yep.
And then the CHADS, it's CHADSVASC score,
Yep.
or CHADS 2 VASC also. There's a couple of them. And it's a calculator. You just put in your age. I think it asks about high blood pressure history, heart failure history, stroke history, that kind of stuff.
Hmm.
So that's what we use to determine whether a patient should be on an anticoagulant in the setting of AFib.
Hmm. Okay. And I know too, I mean, we have one person that's involved with our organization. He came to the determination that because his passion in life was bike riding and he was unwilling to give that up, that, maybe an anticoagulant wasn't the best choice for him, because of the, potential complications that would arise if he was in an accident.
Right.
So I think, just kind of having a conversation with your provider about your preferences, and what's best for you is really important.
Absolutely. I think there's no better time than COVID time to understand that. We all take risks,
Hmm.
and some of us are more risk averse and some of us are not. And so what we need to be armed with and what patients need to be armed with is information. And then you can make that determination based on your knowledge of your risks, just like we choose to get in a car and drive, to the grocery store every day.
Hmm.
So,
Yeah, yeah, absolutely.
mhm.
Absolutely. Personal preference and risk. That's a big part of all of this.
Right.
Is interesting to kind of see how the patient, kind of participation in their care has really evolved. Um,
Yeah, I think it's it's nice. I think I enjoy it most of the time, I'll say. Sometimes it's challenging, and that's okay. I don't mind being challenged. And like I said, sometimes patients come up with really great stuff that works out well in their favor, and you have to be your own advocate.
yeah,
And so I think we do get better care when we advocate for ourselves, but you also have to be willing to listen and learn and acknowledge, you know, uh, I mean, if you're coming in for my opinion, that's what you're gonna get.
right,
And it's just
right.
one opinion, that's the honest truth.
Yeah, definitely, definitely. Well, thank you so much for your time this evening, Dr. Anderson. This was, really informative and really helpful. And I'm sure the patients on the phone got a lot out of it, or on the call got a lot out of it. And we really appreciate you answering all our questions. So thank you so much.
My pleasure. Have a good night.
All right, thanks. And thanks everyone for joining us. We do host these sessions for you, the patients. So if you have any ideas for topics or, specific questions you want answered, please send them to us. We do host these quarterly. So if you can send them in advance, that will give us plenty of time to plan for the next one. So thank you so much, everyone. We really appreciate it and have a great evening. Bye-bye.
Bye.